Welcome to Distance is No Obstacle, a medical education podcast aimed at providing bite-sized education and information for people working in rural and remote Australia. Today's podcast is about menopause, hormone replacement therapy, and women's health. In this podcast, Dr. Ward welcomes Dr. Sunita Chelva and Dr. Michelle Cotellessa from Hera, a bespoke menopause and women's health clinic in Mount Lawley, Perth, to talk about menopause, hormone replacement therapy, and women's health.
So, ladies, tell me, what is the story with hormone replacement these days?
Well, it's been a dirty word since 2002, I think, since the WHI study. Hormone replacement therapy was highly popular before then, but I think that massive study, which you would remember, and Michelle tells me, because I'm a little younger than you guys, you remember when everyone said, get off the HRT, it's going to cause breast cancer, everyone needs to dump it, doctors need to stop prescribing it, and we stopped talking about it.
Yes, I was particularly distressed about that.
Yeah.
I think because many of the general physicians were, prior to that, recommending hormone replacement as being something that reduced risk of osteoporosis, cardiovascular disease, and surprisingly bowel cancer.
Correct. True.
And I thought, it wasn't really one study, was it? It was a great group of studies.
Correct.
With
a
collaboration. Huge age
Right.
difference, and they'd been using hormone treatment for sometimes 20 or 30
Oh, that's
years.
right.
Correct.
Yeah.
And I thought, I'm not sure that we have an actual cohesive test group here. However, yes.
And lots of things came out of it that they did not set out to actually test. And so...
Yeah, well, that essentially what it was. The initial cohort were what women were on average age 63.5 years of age. Yeah. And often these women had, other comorbidities when they came into the study. So the initial study was to look at prevention of cardiovascular disease. Is there secondary, is there primary prevention? Can we reduce cardiovascular disease even in women that have some risk factors? So they were looking at that as well. But there were lots of arms.
Different arms. Another arm was the low-fat diet.
Yep.
Vitamin D and bone density.
Osteoporosis risk,
But the upshot is, I think in 20 years there's been a few studies that have looked back at it and shown that there is a lot of valid evidence there that actually that tagline from the media that came out and said HRT caused breast cancer was statistically insignificant and incorrectly dispersed.
Correct, yeah. And what actually did come out of that study is that women that were in fact on estrogen only have actually fewer diagnoses of breast cancer. So that has actually come out of it, which is a positive thing. Yeah.
And it was really linked to the progesterone arm, or the synthetic progesterone arm, the medroxyprogesterone that was purported to cause breast cancer, not the estrogen, which at the time was the conjugated equine estrogen. And like you rightly said, Olga, a few amazing things came out of it, and that's been repeated in future studies about the fact that it actually reduces the risk of bowel cancer. And the estrogen-only arm did show reduced risk in breast cancer, and there is cardiovascular benefit, and there is benefit on bones. So, this is where we've done an about circle, but we're looking back with hindsight and being, more cautious about it. But
and we
have more information.
I think it's been very much like the measles, mumps, rubella
autism
thing and autism.
Yeah.
So hard to undo that one flawed study. Yeah.
Correct.
30, 40 years later.
Correct.
That's right. It was released in 2002. But the other part of it is we've learned so much from it as well that we need to target women that are younger. That women that are within 10 years of their last menstrual period or menopause, where they're going to get the greatest benefits versus the risks. So the cohort is very different too.
So I noticed after that hormone replacement therapy got rebranded to menopausal hormone therapy.
I don't know.
What is that for?
They've tried to, I don't know. They've tried to, I guess now we have a lot of, hormone replacement therapy is the umbrella for many things. And now I guess in terms of transgender medicine is a very emerging space that that could cover hormone replacement, it could cover many, many things. Yeah. We personally like hormone replacement therapy because it is replacing your hormones to a normal biological level. It's not just in menopause, as Michelle said, it's often before you actually hit menopause. And nowadays it's thought to continue for as long as the benefits outweigh the risks, which could be indefinitely. So it has been rebranded to many things. MHT, MRT, HT, HRT, whatever acronym you want to use. We just call it HRT.
It's just terminology, right?
Yeah. Super. Okay, so a lot of the patients are about 40-ish, sometimes younger, and they come in and they say, I think I might be menopausal. I'm having these symptoms. And sometimes their levels will be pretty normal and sometimes they can actually come low in that sort of fluctuation perimenopausal state, which I think for some of my patients seems to last anything up to 15 years. When do you actually label it premature menopause?
Okay, well, it's actually coined primary ovarian insufficiency, and it's actually
they've rebranded that one.
That's right, and it's actually describing when menopause occurs. So when your last menstrual period occurs before the age of 40 years. So quite a few years ago, we thought it was probably about 1% of women. Now, in fact, it's about 3% of women. So there are a lot of implications with premature, primary ovarian insufficiency in that women are at higher risk of cardiovascular disease. They are at higher risk of osteoporosis and higher risk of dementia. So actually finding those women and treating those women is actually very important as well. Yeah. So, menopause by clinical definition is when you're, it's 12 months after your last menstrual period. Now, that's always going to be difficult when either you don't have a uterus or you have a Mirena IUD that women often are not bleeding. But, and I think that's the key of actually looking at other symptomatology that they may be presenting with as well. And the average age is about 51 of menopause, but it can be anywhere really between 45 and 55, really. And then you've got your early menopause, which is, your last menstrual period before the age of 45. So that's about sort of around the age, about 5 to 8% of women. Yeah.
And we like to describe it as ovaries stuttering to the end. So they're really just, as you said, the hormones are very fluctuant. You can have high estrogen symptoms, low estrogen symptoms. It can be all over the place. It can go back to normal. It can come back to craziness. It can go away. A period can go away for 6 months and come back regularly.
Come back every 2 weeks.
So it's the one thing certain about perimenopause is that it's completely uncertain and it can last an average of 3 months to
10 years,
15 years. It really varies and it's it is a very clinical diagnosis, as Michelle said. It's not exactly 12 months after your period. So on that note, I guess we do say to our patients as well that contraception is really important around this time because you may be 12 months past your last period, but you could throw out another shiny egg.
Especially when you're under 50.
So
yeah, that's right.
The last hurrah. I always tell them it's like an old car that's kind of trying to conk out and then hitting so long a bit and start some days but not on cold ones.
Well, occasionally we have patients who are 55 having very regular periods and you miss that sometimes if you don't ask and realise that that's actually just normal and they're not menopausal.
So when the patients are requesting testing, what do you actually offer them?
They love tests, actually.
They love having a test. They want a number that tells them. And, of course, sometimes I have to explain to them that this is going to check your levels at the moment that needle goes in your vein and it's not going to tell me anything about yesterday, tomorrow or next week.
Or even an hour before. I think in perimenopause it can be so variable that, I mean, we're looking at estrogen, progesterone, luteinizing hormone, follicle stimulating hormone. Really definitively, you're looking for a follicle stimulating hormone over 25 persistently. But as we said, in perimenopause, that can flip in and out depending on which time.
Yeah,
so
that's exactly right.
We might do it for interest's sake. You'd definitely do it for a woman who's under 40 who suddenly stops having periods or florid symptoms. And you don't need to do that FSH level 6 months apart. Once a woman under 40 has an FSH of over 25, that's not normal.
That's exactly right.
So, it's got to be
So there'd be those
seriously.
reasons. Or, for example, I've had women that have got a marina in and, they don't really know, where they are in their whole menstrual cycle. So quite often checking an FSH and if it is persistently above, or even one FSH or two FSHs, between 6 weeks apart, you can actually, if you get a consistent level above 25, you can be fairly certain. Nothing's ever absolute, but you can be quite certain that their risk of pregnancy would be pretty low. But, but in terms of like what we were saying, perimenopause is fluctuating. It's that transition time, between, when your ovaries are starting to decline and they're just stuttering, and it can last such a long period of time. So really there's too much fluctuation to check hormones, except for those very reasons.
Yeah.
There's lots of other tests that you can do.
Yes, I was going to say, what else is useful?
Well, another thing that's not useful, I'll just say that some people have thought that AMH, the anti-Müllerian hormone, might be useful, but apparently there's not a great correlation. There's obviously some correlation to having, if it reflects follicle count, that you've got a low AMH and a low follicle count, and then you might head into earlier menopause, but it doesn't diagnose it, nor does it predict it. So
I guess if you were 35 and wanting to have a kid, then that's would be
important.
Definitely, that's where it's really important. If you've got a low AMH, then obviously the likelihood as well of you going into earlier menopause is actually a lot higher too. Yeah. So there are lots of other tests that we can do because obviously, when a woman comes to see us, it's quite a holistic approach to a patient where you'll be taking, a history and sometimes an examination and then determining where they're at really. But looking at screening a woman as well, as quite often would ask, if you've ever had a bone density or when your last mammogram was, when your last cervical screen was. And then looking at all their other metabolic risk factors as well, particularly if they're, perimenopause, early menopause, wherever they are really, but looking at metabolic factors. So lipids, blood glucose, are they having really heavy periods as well, which is really common in perimenopause. You can have extremely heavy periods, fluctuating periods, so risk of iron deficiency can be quite high. Even thyroid function.
A lot of the patients will complain about the lack of energy and the brain fog and the no libido. Do you guys test testosterone?
We do androgen studies quite often, and we do look at the total testosterone. Useful if we are going to prescribe testosterone, useful perhaps if they've had a history of polycystic ovarian syndrome and therefore higher androgens, or if they have androgenic symptoms, but not routinely perhaps at the very beginning. That may come later.
So certainly something, we do, most of the time after starting HRT, if they choose to start HRT, and we're looking at starting testosterone after discussion, then we definitely get some baseline testosterone levels and monitor.
And every now and again, I guess when we do, Michelle's talking about doing general blood tests, so looking at blood counts and kidneys and livers, but thyroid is something that often pops up around this time. So certainly any autoimmune conditions, but as you said, metabolic issues, vitamin D, iron, occasionally if someone has high risk for osteoporosis, fasting metabolic bone studies are really important to see, is this woman going to be someone that we're worried about because she's losing a lot of bone at this time, which we actually think perhaps occurs even at the beginning of perimenopause, even though there's fluctuating estrogen, that there is bone loss occurring, not just after the last period, but even in that period before.
I like them. They're at least relatively accessible for rural patients.
Oh, that's
and they
good.
don't have to wait for the 2 years for the bone density van to come round to their town again.
Yeah.
It's not all our patients are always able to go to a
That's
larger
right.
centre to have a bone density done. And I think it gives you a bit more of a dynamic picture longer term. But there are some rules about how often you can order such a thing, aren't there? You can only order one every 2
Terms
years.
of how Medicare covers you.
Maybe Medicare, maybe once every 2 years. But even just between having your bone densities, particularly if they're osteopenic, and you want to monitor it, that's actually a good way to do it, just between screening.
Is my medication working?
Correct.
That's right.
Yeah.
So there are so many things on the market that are sometimes available.
That's
and the supply issues have been driving many of my patients completely
and they will continue to do so, yes.
And so many of them, of course, on private prescription.
Correct.
So there's a pink tax as well.
Yeah.
What sort of combination-y things do you recommend as starters that are actually available?
Well, there's so many different types, but we generally try to prescribe body-identical hormones.
First line.
So hormones that are much like our own hormones, so body-identical progesterone, Prometrium, either cyclically or continuously. Not on the PBS.
No, I was going to say also pink
not
tax.
on the PBS,
on the list,
unfortunately, but on the list.
And supposed to have been looked at in November, but who knows when it's going to be looked at. Estrogel is the daily gel that often comes together as a pack with the Prometrium and is a body-identical estrogen for daily use.
What's the estrogen in Sandrina?
That's also estradiol. Also the same.
17-beta estradiol. Yeah.
So again, body identical, great. On the PBS, very accessible.
Most of the time.
Takes a longer time to dry, Sandrina versus the estrogel. Patches are awesome. They're on the PBS, but we cannot get the ones that really work well, which is the Estradot brand, and that I believe is going to go into next year. So the shortage, even into the end of next year. So that's a long-term difficulty that we're going to face. Certain patients can do very well with oral estradiol as well, certainly if they have low risk for VTE, they're younger.
Yeah, quite a lot of women.
We often forget that is a very useful option.
So what is the thing with higher cardiovascular risk or just thromboembolic risk?
Venous thromboembolism.
With oral?
Given that it's metabolised through the liver, there's going to be an increased risk of VTE. So I guess like the pill, you would avoid people who have classical migraines with aura, and any prior thrombophilias or history of DVT or stroke. But aside from that...
But for majority of women, especially now with the estrogen patch shortages, quite often we would go to use oral estradiol. So really a lot of women are low risk. A lot of women aren't at high risk of VTE. And but transdermal is definitely the preferred option, obviously, for women with VTE risk.
Yeah, and so I like the idea of the bioidentical things. Some of the patients
the Americans like bioidentical.
Yeah, some of the patients tootle off to Perth and gets one of these trash things made up, usually by their naturopath. I never quite know what's in it because the labelling is often a little dodge. But even if it's, I can't quite get my brain around it because I couldn't find any useful information. No. Is there a site where you can find something
we
about
don't prescribe, but we don't tend to prescribe bioidentical hormones. That the whole movement sprung up after WHI because clearly, people did realise that women lost their hormones and they needed some degree of it replaced. And whilst some of these are like our body's hormones, the very act of compounding, no matter how good the compounding pharmacist is, we don't know about the variability of composition. And also they're not TGA approved, so we don't know about the reproducibility and reproducibility in the uterus and the end organs, the breast. We don't know. So whereas Michelle and I, when we prescribe body identical hormones or not non-body identical hormones, we still try and do it like we would prescribe anything else, like thyroxine or insulin. It's going to be at a certain dose and watching the clinical response to that. So it's more measured and measurable and reproducible, I think, and more scientific in our mind. Yeah.
So what happens when the patients are having side effects? You know, what things do you adjust for what sorts of side effects? Or do you just say change the progestogen or change the formulation?
Okay. It really does depend on their side effects as well. So, you know, when you initially prescribe, generally it is looking at the woman in front of you, and you can kind of, you know, there's no strict guidelines, you know, in terms of, you know, how you prescribe. But generally, say if I'd start estrogel, I would start with one pump on one arm for a week or so, and then gradually increase
so start low,
to
go
2
slow.
pumps daily. And generally their maximum concentrations will get up to about 4 to 6 weeks, and you can see, you know, that the responsiveness. But commonly with estrogen, you know, women may get some breast tenderness, but it's very transient, and it is very, you know, it doesn't last too long, and it tends to settle.
And you still advise arms
or thighs.
Legs.
Yeah. Arms or thighs.
I've always said sort of lower abdomen or legs.
Large surface area for estrogel and palm-sized surface area for Sandrina.
Yeah.
Okay.
But side effects of estrogen would be breast tenderness, headaches, bleeding.
Yeah, and bleeding. Yeah. So bleeding in that first 3 to 6 months of commencing is not uncommon. But with, for example, prometrium, so your micronized progesterone, there are some women that are more sensitive to progestogens, and normally you can pick that up from history, potentially women that have had, say, side effects like mood side effects with the combined pill, or particularly mood side effects even with Mirena, and then your other progestogens, contraceptive, implanons, etc.
Or women who have PMS.
Are very often quite, and PMDD are very sensitive to progesterones. So it's just listening to that in the history. And then oral prometrium is generally really well tolerated. And the really nice thing with majority of women, they get a really nice sleep effect. So you take it at bedtime. So it's quite sedative and also quite a calming hormone. Now, not all women get that response, unfortunately, but still tolerate it well, which is a shame, because we know that sleep disturbance is a huge issue. And we do use it off-label vaginally as well for women who cannot tolerate it orally. So you just use, say, instead of, say, when you use it cyclically, you'd use 2 capsules, 2 weeks out of the calendar month. You use 1 capsule vaginally for that 2 weeks out of the calendar month, and it bypasses the liver. So it can reduce those side effects of bloating, fluid retention, and mood irritability as well. Yeah, that's another option.
It's a really good tip. I'd never thought about using it vaginally.
I guess it works. I mean, for fertility they use it in that fashion, but I guess if you're using it therefore just for endometrial stabilisation, you're delivering it closer to the uterus, and that's what it's doing, really. Yeah. Michelle, with all of this sort of thing, I guess you're asking about side effects, but Michelle has a nice way of describing this in that it's like a recipe. So often that you do have to increase the estrogen or decrease the estrogen, or increase the progestogen or decrease it, and it all has to, each woman will need a different amount. There's a great variability in how women absorb things through the skin. So I, sometimes would have patients who use half a pump, and they're great. Their symptoms are under control. I would have another woman who might be on 6 pumps of gel, and that's what she needs. But if you actually look at their blood levels, because we're sometimes looking at that, and their symptom response, they're actually going to be about the same. So it really depends on an individual's variation in skin absorption. There's no hard and fast rule, and that's
don't
tricky.
Absorb estrogen transdermally either. Correct. And that's where we change to oral as well. But it's often after review. I think, Olga, is really important, is actually following up patients closely, and the ones that you are concerned about, they need closer monitoring as well. And it's very recipe-based.
There's no one-size-fits-all. I think that's why women weren't included in studies until the 1990s. Talking about this before, but because we're very complex. We have very complex physiologies, I think.
Absolutely.
So what about the patients who really are terrified of taking something hormonal because they've had early breast cancer or their mother died of ovarian cancer or whatever? Is there anything we can offer them for symptom management?
Absolutely. And I think, the other important thing is when you talk to a woman is really understanding her fears, because there are a lot of myths about, breast cancer risk and HRT. So actually dispelling some of those myths. Often I have patients that would come in and say either they've been told that they can't have hormone therapy or I know I can't have hormone therapy or I'm scared of this. Is actually education and awareness of what the true benefits and risks are, and quite often that can change that momentum of the conversation.
But I think I've had this conversation with patients maybe 3 times this week, and it's been something as simple as utilising vaginal estrogen in the postmenopausal atrophic woman, and they're like, oh, no. I've got a family history of breast cancer and I can't possibly, or I had breast cancer and I can't possibly use this.
Which now we know that all international societies, menopause societies will say that is actually absolutely fine to use after breast cancer, family history of breast cancer. The sad thing, Olga, is that a lot of the inserts, so in your Ovestin or your VagFem, still says this is going to cause breast cancer, this is going to cause a clot. And so women really get terrified when you prescribe it. And go, what has the doctor done?
And quite often telling them to throw it away before they even read it.
That's right. Don't look at the
But then
insert.
they'll go and consult the pharmacist and the pharmacist will go through it. I've also had to have arguments with not too many pharmacists because most of them are pretty sensible, but every now and then.
We're still very scared of hormones, I think. This is, I think we were talking about that before, this hangover that still, percolates around that where
there's a fear,
any hormones
especially
are
doctors and women, really. So, but there are non-hormonal options, absolutely. Particularly for women, we do see quite a few women who are going through breast cancer treatment. So, certainly a woman who has been treated and often treated with their breast cancer with, their first starting with their medical treatment, so their GnRH analogues or tamoxifen or anastrozole, which will put them into a medical menopause. So you have women who are...
Well, I remember it. It was not fun. Oh. It was absolutely not fun. But
horrendous.
Yes.
Common.
And especially, from a premenopausal state and going into, an acute menopause. So
what else is around for those women apart from...
So traditionally there are antidepressants, SSRI medications, gabapentin. We don't tend to use clonidine because of side effects, but sometimes we use oxybutynin. Those are really sort of targeting vasomotor symptoms.
And mood, I think.
And mood and anxiety. There is, there are medications that are emerging. There's one called Veoza, which is the neurokinin 3 receptor antagonist in the brain.
I don't know anything
so this
about
is a brand new one, which, acts on the fact that actually vasomotor symptoms and hot flushes occur in the brain. So this is a non-hormonal medication. Now, unfortunately, it is still being studied as to whether it can be used post-breast cancer. We don't have the data on that yet. But can be a non-hormonal option for women who either can't or don't want to take hormones, and is fairly effective at combating hot flushes, night sweats, and also can help with sleep. But certainly in terms of a comparator for women who can take HRT, it doesn't have the benefits on brain, bone, heart.
What happened to Tibolone? Do people still use it? It kind of appeared with great fanfare and nobody ever prescribed it. And I wasn't quite sure whether that was a dollars effect or whether that was a...
I don't know how effective it was.
Well, I used it a lot in general practice many years
when
ago.
When
it was fashionable. And I think really the good thing was the effect on the breast was quite neutral, particularly women with breast density. And also I think the other thing was libido.
Yes.
I think that was it's highlighted great effects.
Androgenic effect.
So it is still around because it's a receptor effect. It's a SERM. So it will act on the receptors. So it's not hormone therapy. It behaves like it can be, but it's not quite the same. So it just targets receptors. So look, I don't tend to use it as much anymore.
In older age, there were some things about
it's got a higher
cerebrovascular
stroke risk after the age of 60 was one of its.
So I think that's
one
why
of its sort of downsides.
Well, that's why possibly we don't use it anymore. Exactly, because a lot of our women are in their 60s going, I'm going to live another 30 years. Yeah, exactly. I'm not going on this. So
yeah.
But I mean, the most important thing, Olga, that we forget also, I guess, is diet, exercise, mental health, sleep. All of these things are so important for our women post breast cancer or any other hormonally receptive cancers.
And having just come back from the wheat belt in the summer, I have to say air conditioning also has to be right up there.
Yes.
And lots of layers you can peel off.
Yeah.
Some of my patients are also finding, and in fact, having had a quick chit-chat with colleagues, are also finding that their menopause is affecting their other medical conditions.
Absolutely. Nothing is in isolation.
Sort of metabolic kinds of things are you seeing? And, you know, do we just kind of look at maybe replacing their hormones in addition to, or do we just kind of double down on the medical effects, say for their type 1 diabetes or their Crohn's disease or whatever?
Well, I guess, you know, I mean, estrogen by its nature is quite an anti-inflammatory hormone, and you know that it affects all body
every
systems.
cell in the body.
It is a, you know, there are receptors in every single part. So I guess, you know, probably a lot of the medical conditions that I would see in practice would be women with even inflammatory arthropathies. So, and the impact of adding in HRT for their other symptoms has actually, I found, had quite a positive impact on even just in conjunction with their immune modulators, can have a really good effect on reducing joint pain and reducing joint swelling. So it's actually been that positive. But in terms of things like insulin-dependent diabetes, you know what I find really is if you are, you know, feeling fantastic and feeling a lot better within yourself, you're eating well, you're sleeping well, you're moving your body, quite often a lot of those other metabolic processes might improve as well. But I don't know if there's any direct correlation between IDM, you know.
Well, I think...
But indirectly, I think you could see.
Directly, I think even with type 2 diabetes, I guess we know that the perimenopausal stage of losing estrogen, progesterone, testosterone, we do by nature become more hyperinsulinemic.
And insulin resistant.
By virtue of losing gut microbiome diversity, by losing
muscle.
Skeletal muscle. These things, I guess, with someone with a comorbidity will worsen their picture. So I think you may have talked to us about this, that certainly someone in perimenopause will find where they were a well-controlled diabetic, it'll start to decline and they'll start to have loss of control following their hormones. That chaos seems to overlay everything, given, again, that all these hormones occur in every single cell of our body. So I think whatever a woman has, not only are a lot of diagnoses unmasked around perimenopause or menopause, a bit like puberty, they seem to decompensate as well. One of the things I find very interesting around this time are, and I don't know if you see this with your patients, but neurodiversities seem to flare or become apparent around this time because of the impact of estrogen, progesterone, testosterone fluctuation or loss in the brain. So that is something that people will find they really struggle with. Pre-existing ADHD.
Do you think that's because of the lack of hormone causing brain fog? And so that they've got
yes and no, but
another interrupter
directly. I think
probably more on neurotransmitter.
Correct, on the sort of
fluctuation
and serotonergic,
GABA,
GABA
I think
pathways.
Probably more direct. Yeah. And the other interesting thing are lipids. I'm sure you found as well that women that, you're monitoring lipids over a period of time, just as you would in general practice. And then often in perimenopause, you see that change. Total cholesterol starts to rise. LDL starts to rise in perimenopause and menopause.
Whilst they're doing nothing different. So women get very frustrated. I mean, they get frustrated with the weight gain, the abdominal girth.
Terrified of going on the hormones in case they get...
It's going to make me put on weight.
Yes. But in actual fact, it doesn't.
It should normalise directly, as well as Michelle was saying, if you're feeling better, you can plan your meals, you sleep better, you exercise with more vigour, then great,
But
There's
definitely
effects.
estrogen, estrogen in hormone replacement therapy absolutely can reduce your total cholesterol. We know that for a fact. And the other thing is hypertension. You see hypertension start to creep in midlife as well. So estrogen is very protective of our, cardiac disease, our vascular system. So it actually has a vasodilatory effect, particularly on our coronary vessels, but other vessels as well. So quite often you can see blood pressure starting to drop a little bit. Now, obviously, there are women and men who need their blood pressure tablets, but quite often you can find you might be able to reduce those blood pressure tablets down. So it's amazing the effect on the metabolic system, the cardiovascular system. Yeah.
Now, I am aware that we could chat on all day, but that we probably need to wind this up.
Yep.
Take-home messages?
Don't be afraid of HRT. I think that a lot of women are actually very educated and there's a lot of awareness out there, but I think us as doctors sort of have still got more of a hangover from this. Listen to what your patient's saying. I think a woman, by the time she gets to her 40s or 50s, knows her body and she knows what's going on. And if she's seeking help, don't be afraid. Start with something simple like Prometrium and Estrogel. You can seek help. There's a lot of information now for doctors on the internet as well. We're happy to take calls or emails as well, but definitely be brave.
Website that you go to, Jean Hales or Australian Menopause Society?
The Australasian Menopause Society, the International Menopause Society.
British Menopause Society.
The British Menopause Society is fantastic helpful. As well. But I think starting watching your patients, listening to them, following them up at timely intervals, seeing them as a whole person.
Yeah. And women, there are women that present with multiple symptoms, that sometimes you just can't make sense of. Just keep perimenopause in your mind, for those women. A lot of women are very simple and present. There are women that just, classic symptoms, but there are many that aren't. And women struggle, so particularly mood. And I think that's just being aware of that as well. Yeah. So that would probably be some of our take-home messages. The listening is integral.
Is the main part of what we do. It's not the hormones.
And just keep it in the back of your mind. Can this woman be in perimenopause? Is this what's causing that multitude of symptoms that
or worsening whatever's going on underneath?
Yeah.
Fabulous. Well, thank you so much for joining us today. I think it's been a lively discussion and hopefully we'll come back and talk about some other things, women's health, some other time.
Absolutely.
Thank you
Thanks,
very
Olga.
much for having us. Yeah.